Good morning, everyone. Welcome to Munson Healthcare's COVID-19 press conference. Today is Tuesday, January 18th, 2022. My name is Diane Mihalik. I am the Chief Marketing and Communications Officer for Munson Healthcare, and I will be your host today. Today, we are excited to have Dr. Christine Nefcy rejoin us. She's the Chief Medical Officer for Munson Healthcare, and she'll be giving us an update on the current state of affairs of COVID-19 at Munson Healthcare. And then we're also excited to have a new speaker today. His name is Dr. David Gordon. He is the Physician Chief of Cancer Services for Munson Healthcare, and he's going to be offering a unique perspective on COVID-19 and what that means for our cancer patients and for all of us who are either taking care of cancer patients or interacting with them. So without further ado, I'd like to introduce Dr. Christine Nefcy, who will give us an update on the numbers. Welcome, Dr. Nefcy.
Thanks, Diane. All right, so I think everybody is probably very aware that we are seeing large increases in the number of positive COVID cases across Michigan and in our community. I won't read you those cumulative numbers, but I will point you down to that box at the lower left that shows our percent positivity. So you can see there we are at a 32.3% rate for the state of Michigan, which is quite high. And then when you look at the daily average, 39.1%, which again indicates to us that we will continue to see those numbers go up. Next slide. If you'll go to that same box, you'll see our regional data. We aren't quite as high as the state, which is nice. We're at 22.5%, which is also still high. But you can see there our daily average is also significantly higher at 35.2%. So again, an indicator that we anticipate our percent positivity and our number of new cases will continue to increase. Next slide. So here you can see the long-term graphic of where we are with our inpatients. So you can see towards the right side of the graph there, our last surge, which was kind of that longer, slower rise that we saw with the Delta variant, a decrease, and now we're seeing an uptick with Omicron. Next slide. So here is, as of this morning, 87 hospitalized patients with COVID-19. 33 of those are vaccinated. I do want to point out only 5 of those 33 are boosted. So again, the vast majority unvaccinated, but definitely seeing an added protection from a booster shot. In our ICU, we have 23 patients with COVID-19. 8 are vaccinated, none of them are boosted. 9 ventilated patients, again, 2 vaccinated, none boosted. So we are starting to see more vaccinated patients come into the hospital with COVID, but again, the vaccine is very clearly protective, and we would, as we have been, strongly recommend everybody in the community get a booster shot if you haven't already. Next slide. Here we wanted to talk about, we do hear a little bit about why is this such a big deal? Why are you talking about this? You know, that's not that many patients. You have 400 plus beds at the medical center. But we did want to, you know, just put into context where we are now compared to where we are traditionally. So if you look here at our overall patient volumes compared to past years, we are up 15%. And then if you look at our inpatient volume compared to where we are for COVID-19, a pretty significant increase there. Another way to just look at the same data, 1 in 6 hospitalizations across the Munson Healthcare system in December to January was due to COVID-19. So a lot of patients in our hospitals for COVID and just more patients in general.
Dr. Nefcy, let me stop you there just for a second, because we do get this question quite a bit as to when we report on there's 87 or there's 90 COVID patients in our hospitals. We do get a lot of questions on social media that says, well, why is that a big deal when you have over 400 beds throughout your healthcare system? So can you just explain that a little bit more as to what we would normally see this time of year?
Yeah, well, we would see a lot fewer patients. Winter, with the exception of kids, tends to be a slower time in the hospitals. So that's why we thought it was important to kind of show this, that our volumes overall are up. I think the other important part is when we report out those COVID patients, those are patients that are in isolation. And what that means is a lot of extra care. So the PPE that's required, how those folks are monitored, the staffing, there's a lot that goes into taking care of those patients that is really much more intensive than it would be for a patient not with COVID, traditionally speaking. So, this just shows you that we are up overall, not just with COVID, but with other patients as well, significantly with that, and just much busier than we typically are. And then that is on top of staffing issues that we've seen nationally, and then now with Omicron, an increased incidence of our own employees being ill.
And are we also seeing the number of COVID patients staying longer in our hospitals as they were earlier in the pandemic?
Yeah, it's a good question. We are seeing an increased length of stay overall, as we pull that out. There's some initial data that will have a shorter length of stay for people hospitalized with Omicron versus Delta variant, but that hasn't quite panned out yet.
Great, thank you.
Okay, so this is some data from the CDC that we got through the Michigan business leaders. And that shows you here that only 25.6 of our population has been boosted. That's that orange line down at the bottom. And then you can see the rest of the population there that has had 2 doses. Go to the next slide. I think that's important to understand that with either natural immunity, so having COVID or being vaccinated, that's still only 76% of the population that has some immunity. So only 25.6 of the population has been boosted, which we would say has kind of the best immunity. 76 has some immunity. That still leaves almost 2.4 million people in our Michigan population that are not don't have any form of immunity, either through having COVID-19 at some point or through being vaccinated. So that's still a lot of people that have the possibility of contracting COVID and becoming quite ill with it. Next slide. So again, this is where we come to the point of you guys helping us move the needle and coming together to be vaccinated and to get your boosters. Just as a reminder, both the FDA and CDC are recommending boosters. The FDA and CDC have approved Pfizer's COVID-19 booster dose for children aged 12 to 15. They have shortened the timing of getting your booster for Pfizer or Moderna from 6 months to 5 months, just to get more people in and vaccinated. And again, if you've received the Moderna vaccine and are 18 years or older, you can get a booster after completing your primary vaccine series. And then if you've received Johnson & Johnson and are over the age of 18, you can get a booster at 2 months after completing that first shot. So let's just go over a little bit of the Omicron variant. So again, these are estimates of percentages based on sequencing that's done, which is a very small percentage of total cases. But the CDC is estimating that nationally, 98% of our new cases are from Omicron. And we are following closely behind in the Midwest with an estimate of 97%. The Michigan Department of Health and Human Services has sequenced Omicron specifically in 41 counties, but again, that is a very small sample size, and then they extrapolate from there and do believe that it is present in likely all of our counties and is the majority of our new cases. Early studies show that this Omicron variant is much more transmissible than Delta. And Delta, again, is much more transmissible than the original strain. This is why we see so many more new cases. This is also why you're seeing changes in recommendation for masking. As far as the severity goes, again, there are some preliminary studies showing that while Omicron is much more transmissible, it is not as lethal. So South Africa showed 80% fewer hospitalizations. You know, there are some nuances about South Africa, the youth of their population, their low rate of vaccination, and probably higher rate of natural disease. So as we look at these studies that we see from places like South Africa or Great Britain probably is a little bit closer aligned with the United States as far as age distribution and that kind of thing. But what it does show is that we hope and think that there will be fewer hospitalizations as a proportion of people infected. That being said, with the pure number, the denominator alone of people being infected, we do expect to see a higher hospitalization just in raw numbers, which we are seeing downstate. And again, on vaccine effectiveness, a British study showing 2 doses of protection against infection was about 0 to 20%, but that booster did increase the level to between 55 and 80%. So can't stress enough how important getting your booster shot is. And then moving on to testing, sorry, it is important that you follow. If you're going to take a home test, please follow the directions on it. You know, these tests are uncomfortable. You have to stick that swab up your nose and leave it up there and twist it around. In order for that to be accurate, you should be in I don't want to say don't hurt yourself, but it's uncomfortable to take these tests. And if you don't do it correctly and follow those instructions, there is a higher likelihood that your test will be inaccurate. So it's just important that you follow the rules, look at how you're doing it, and make sure that when you're doing that test, that you're doing it as best you can. There is different forms of tests between PCRs and antigen testing. But you know, just follow the rules for that and ensure that you're doing it correctly. Excuse me.
Dr. Nefcy, I'll let you I hope you have a drink of water there. But you know, we have gotten a lot of questions about, can I use one of the nasal swab test kits and just swab the back of my throat? Could you comment on that, because it doesn't sound like that is what those tests are meant to do.
Yeah, it's important that you follow the directions for that particular test, because when those tests are studied and always when they come, so even when we do this in our own lab, when we get a new test, we actually will, you know, take different specimens and ensure that we're getting the results that we should be getting, you know, that a positive is a positive, that a negative is a negative. And when they do the tests and they show the sensitivity and specificity of these tests, they're done in how they direct you to take the sample. So a throat culture is done from the throat. A nasal swab is done from the nose, and going back and forth is not recommended. And especially when we've got, you know, the vast differences in who these tests are coming from and that kind of stuff. It's just very, very important that you follow the directions to the T when you're taking these.
Great, thank you for that clarification. That's a common question we get on social media.
And again, you know, lots of different resources out there for you. Local health departments, your primary care providers, different pharmacies. You can always get onto the Michigan.gov coronavirus website, lots and lots of information there. And then if you don't want to go through your computer, we do have phone resources as well through the Michigan COVID-19 hotline and our own Munson Healthcare Ask a Nurse line.
Thanks, Dr. Nefcy. We appreciate the overview from Munson Healthcare, and it is good to hear that the boosters are being effective against Omicron. So that's really good information there. So if you don't mind, we will have you back for the Q&A session shortly. But next, I'd like to welcome for the first time Dr. David Gordon, who again is the Physician Chief of Cancer Services with Munson Healthcare. And Dr. Gordon, we're just going to ask that you please start your camera and your audio. And what can you tell us about what you're seeing related to cancer patients and COVID-19? Welcome.
Sure. Thanks for having me. Can you hear me okay?
Yes, we can hear you great.
So I appreciate being here. And what I want to briefly do is just talk about why we have particularly and somewhat unique issues in cancer services because of COVID. So the way I thought I would start just briefly is to show, if you think about this, the reason we have a problem is because in order for people to respond either to the natural infection or to the vaccine or whatever, they have to have an adequate immune system. The adequate immune system consists of two parts, one of which is antibodies, which is what we measure when we talk about the antibody titer. So we know that within our patient groups, there are a certain group whom are at great risk, and logically they should be at great risk, and there is data suggesting they are at great risk. And they're listed, this is a guideline, this is not a CDC rule, but they are listed in tier 1. So patients who have had a stem cell transplant or the sort of part of stem cell transplant, which is the newer thing in cancer therapy, CAR T-cell therapy, or solid organ transplants, those people, basically it takes at least a year, maybe more, for their immune system to recover. Lymphomas are actually malignancies of the immune system, so it's perhaps not surprising that lymphomas are at particular risk because their immune system doesn't work. And in the treatment of a number of diseases, including lymphomas and some other diseases, there's anti-B cell immunotherapy. What is that? Well, the B cells are the ones that turn into the plasma cells that make the antibody. So if you're on an immunotherapy that turns off those cells, it's perhaps not surprising that you're not going to be able to manifest a good response. And people are on concurrent chemotherapy just because it really affects all cells. So patients in tier 1 are at great risk for us. We'll talk in a second about what we do in that setting. There's another tier, which is probably puts these people at higher risk than the normal population. They include patients who are on high-dose corticosteroids. This might occur in autoimmune diseases or some neurological diseases, or if they've had chemotherapy in the last year, we know that their ability to manifest a response is less. There's other immunotherapies that are used in autoimmune diseases, which can affect the immune response. And then, of course, there are just basically comorbid conditions. If you have COPD, which is a lung problem, and you get a COVID infection, you're not going to do well because your lungs can't manage. So if I could have the next slide, please. So what are the issues that we see in hematology and oncology? Well, the first issue, and in some ways, maybe the most important, is infectivity. Because if you think about it, since our patients are at risk, the people who can infect them are really important to us. So we're really on board when we talk about all the things, and I'll mention this in the last slide, that really protect people from being infected from somebody else. People need to realize that if you have an infection, even if you've had your immunizations, but you still have an infection, yes, you're going to do better, but you are still communicable. So if you're around one of our patients and you're not being careful, that's potentially an issue. And then when our patients do develop an infection, this is also an issue because, not surprisingly, they don't do as well. Dr. Nefcy didn't mention, but I would wonder about those patients who have been vaccinated who are in ICU. I wonder how many of those patients really are our patients, or patients who have the risk factors that I mentioned. And whether you talk about hospitalization or ICU admission or death, all of those issues are worse for our patients if they get infected. So we have a major issue in terms of protecting our patients from infection and instructing the people that they're around, including their caregivers, that this is a really important thing and can be really lethal for your brother, your sister, whoever you're looking after. So the last slide, you could put that up, please. You know, it really isn't any different than it is for anybody else. I mean, as everybody knows, COVID is airborne. And so the better the mask, the better the chances that you won't get the disease. It's also better the chances that you won't give the disease to somebody else. In the cancer center, you know, everybody's masked all the time. This is not an option. Everybody has to wear a mask. And when patients come in, you know, we spend a lot of time talking with them, being very careful. The other thing that's important, it's Dr. Nefcy alluded to some extent, is social distancing. You know, I tell my patients and their caregivers, please don't go out at midnight singing karaoke with a bunch of friends after drinking, because that's probably the worst, you know, but social distancing is important. And in the cancer center, we're very careful about that. For example, if patients have COVID, we have a special way that they come and are treated. They don't go through the standard procedure. And we also, and I'm going to mention it here in a minute about the monoclonal antibodies, we do give those, but that's a whole separate place as well, because we're very careful to maintain social distancing and trying to keep, you know, as sterile as possible, the cancer center. And then there's the issue of vaccines. I mean, you know, people, there almost no vaccine is 100%, but these vaccines, wherever you look, are important. In our patients, many of whom are at the highest risk with the first dose, or maybe even the second dose, don't develop much of an antibody titer, but with the booster they do. And there is data that shows that this is the case. You can also show that people who have been vaccinated basically do better, as Dr. Nefcy has related previously. They get less disease, they get, when they get the disease, it's less, and they end up doing better. So there is really no, and the side effects are almost non-existent. In my own opinion, the only reason that a side effect keeps you from getting a vaccine is if you're truly allergic to things that are in the vaccine, and you have to know that by history. So it's very important that this is taken care of. And just because you've had the disease does not mean that you're not infective or that you're not going to be able to pass the disease to somebody else. And that's no reason not to get the booster as well. Some people say, well, I've already had the disease, you know, I don't need to do anything more. That's actually not true, because it's like a stepwise thing. The more things you do, the safer you are. I just want to finish by talking briefly about monoclonal antibodies. The antibodies that we make, of course, are protective. And so what's happened is not we, but people in the business have been able to develop antibodies, which are monoclonal, that are specific for the COVID virus. And there are two different ways that we deal with this. The first is in high-risk patients. And there is data out there in high-risk patients. I'm going back to like tier 1. These are people who really can't even develop, and even after 2 or 3 doses, cannot develop an antibody response. So you give them the antibody, basically. And there is evidence in the literature that by doing so, you can protect them to some extent. Now, this is only for patients who have not been exposed or do not have the disease. These are just simply high-risk patients. There's another set of monoclonal antibodies that are used in early symptomatic patients, because there's data that suggests that if you give the monoclonal antibodies early in the infection, you can mitigate what the infection might turn out to be. So these are things that are available. They're known to the primary care providers. There are criteria. Obviously, we have to put these in some kind of an order, particularly with a high-risk patient. Those antibodies have been in dear supply. And so there has to be some way that we can ration them out. So we do our best, and it really follows the issue of the risk that I mentioned. So I'll stop there, and I'll be happy to answer any questions.
Thank you, Dr. Gordon. There are just a couple of questions that are coming in right now for you related to monoclonal antibodies. One is the CDC has guidelines for giving unvaccinated individuals the highest priority for monoclonal antibodies. Is Munson Healthcare following these guidelines? And could you give your thoughts and opinions on this guidance? Because would this be a disincentive for someone to get vaccinated if they think that if they contract COVID-19, they can get a higher priority for monoclonal antibodies?
So first of all, the protection afforded by vaccines is infinitely better than the protection afforded by monoclonal antibodies. They aren't even in the same category. The monoclonal antibodies are effective, but they're not anything like the vaccine. I actually am not sure, Christine may know, I think we prefer let me say, people who come who are unvaccinated, we do have some emotional difficulty with because we feel they are not concerned about their fellow people. I think high-risk patients, even if they're unvaccinated, we would do so. I'm actually not sure about the symptomatic patients. Dr. Nefcy may know more about that than I do.
Yeah, there are pretty clear guidelines from the state and other organizations about who gets prioritized. Being unvaccinated is considered being high risk, so they are part of that prioritization. And then there are also the clinical prioritizations of patients like yours, Dr. Gordon.
Thank you both. Dr. Gordon, one more question. You mentioned, what you're seeing and keeping services open. Can you speak to preventive cancer screenings and things like that? Earlier in the pandemic, we heard a lot about some people putting off preventive screening measures. Are you still seeing that in your patient population? And how important is it to keep up with things like breast cancer and colon cancer screenings, et cetera?
One of the problems with this pandemic is there are things that come up that don't have an easy answer, okay? And every day we're faced with a new problem and we have to try to do the best we can. So I think early on, the screening was cut back, and I think to some extent it's still true. It occurs both at the level of the patients who say, I don't want to go anywhere where I might be exposed, but it also occurs at the level of staff. As Dr. Nefcy mentioned, you do screening of some kind, you need staff to do their thing. But I think if the risk is high enough and there are patients, we can get the screening done. But I do think it's a little bit of a problem in the general public.
Great, thank you, Dr. Gordon. Also like to bring Dr. Nefcy back, and we'll get right into our Q&A session here. So Dr. Nefcy, will there be a fourth vaccine or booster dose for Moderna or Pfizer? Do you have any insight into that?
Well, we're certainly hearing about other countries already starting that. There's a lot of conversation about the effectiveness of doing that in a broader context of getting primary doses of vaccine out to others who don't have them. And then, what's the effectiveness of a fourth dose for a small segment of the population when we've got 75% of the population that doesn't even have a booster. So a lot of conversations about that. There is certainly a precedent in some places. Like I said, we haven't, gone that direction yet, but I would say more to come.
Thanks, Dr. Nefcy. Another question, Dr. Nefcy. During the December 30th press conference, Dr. Ledke said a report suggested that COVID-19 reinfection rates may be significantly higher with the Omicron variant. Are you seeing a lot of people being reinfected as Omicron spreads?
It's hard for, to say, are we seeing? Certainly we are seeing that, but that's really, I think, broad kind of national or even international data that we're going to have to accumulate to really look at it. But I would say, yes, what we are seeing is there certainly seems to be more reinfection from people who had COVID, naturally prior with this variant.
Thanks, Dr. Nefcy. One more question for you. You noted in one of your slides that Omicron is not as lethal. Could you please clarify what you're comparing that against?
Against Delta and against it looks like it's less, you're less likely to be in the hospital and in the ICU with this variant than you were with that one. That doesn't mean we're not still seeing a lot of people in the hospital, and certainly people are still dying from this variant. Hopefully, and again, preliminarily, less or fewer than what we saw previously.
Thanks, Dr. Nefcy. Dr. Gordon, we do have a question coming in for you. The question is, have you lost many cancer patients because of COVID-19?
I think there have been one or two, but I think we've been pretty fortunate. I don't know whether it's because we've been very careful or we've just been lucky. So we worry about it all the time. I don't know the exact number. I know there have been a few.
Sure. Thank you. And then Dr. Gordon or Dr. Nefcy, I'll start with Dr. Gordon, and we can have Dr. Nefcy comment if you don't know the answer to this. But I have heard that monoclonal antibodies are ineffective against Omicron. I'm wondering if this is true and what you'll do in this case.
So the data that exists for monoclonal antibodies predated really the Omicron data. So it's a little bit of an extrapolation, but I do think that there are similarities between the Omicron virus and the neutralizing titers. You have to understand, people early on talk about just the antibody because that's the only thing you don't have in the clinical history. The neutralizing titers, I think, are less, but they're not negative. So I think the answer to the question probably will turn out to be, although the studies that have been done were not done with the Omicron variant, they were done earlier. I think it probably will be they still work. They may be a little less effective.
Dr. Nefcy, any other comments on that?
Yeah, what we know, again, this changes, and a lot of the science is relatively new, is that the monoclonal antibody we were using is not effective against Omicron. And when I say not effective, it doesn't mean it has zero impact, as Dr. Gordon was saying, but certainly not effective enough to, from a risk benefit perspective. So we have changed the type of monoclonal antibody that we are providing now for the Omicron variant. The problem is that that particular monoclonal antibody is in very short supply. So we've had to severely limit who gets that therapy. And I think that speaks also kind of, to the earlier statement of why wouldn't I just get monoclonal antibody? Because there's just not that much out there. You have to be at extremely high risk in order to qualify to get it. So again, to Dr. Gordon's earlier point, getting vaccinated is the safest and most beneficial route to take.
I could add one thing. There's been occasional discussion about the side effects of the monoclonal antibodies. The reality is they're very, very safe. So I don't think that argument, Dr. Nefcy says the efficacy is not what we would like. We'd like them to work better. They do work, but they really are safe.
Thank you. And could you also just speak to, I've gotten this question, not today on the press conference, but just in the past, about the exact way that you give monoclonal antibody therapy versus, going in and getting a shot, which is very quick and it's over with pretty quickly. How long does it take to actually receive a dose of monoclonal antibody?
So I'll mention it, and then Dr. Nefcy can comment on it. Originally, the monoclonal antibodies were given intravenously, which of course took some time. So you're really talking about time to be set up, put in the IV and do all that. But what happened was, I don't know, a couple months ago, it became clear that the antibodies could be given subcutaneously, which is really just a shot. So now it's sort of like anything else. You get the shot, then you have to wait a while just to make sure you don't have any kind of side effect. I don't know whether Dr. Nefcy can add anything to that. My understanding.
Yeah, it's both now.
Okay.
Kind of depends on where you are and that kind of thing. But the subcutaneous, but then also the IV are still the way that is given.
Great, but it still sounds like being vaccinated for many reasons, not only supply, but effectiveness is the better route to go. So thank you for that clarification. Dr. Nefcy, with the updated infographic, we have been seeing over the last couple of weeks that there were the people that were on ventilators were all unvaccinated. And today you showed 2 patients that are on ventilators who were vaccinated. Do you have any understanding of why those 2 patients are different this week?
I mean, it's hard to extrapolate data broadly from small numbers like that. I think that Dr. Gordon being on is timely. What we know is those patients who tend to be vaccinated and still get admitted or have serious complications from COVID tend to have lots of other medical issues. Very, very frequently, one of them is oncologic in nature. There are other things too. Chronic pulmonary disease, chronic heart disease, and obesity are all significant risk factors, as are age. But a cancer diagnosis is also a very high risk factor for those breakthrough cases. You know, he did a good job, I think, talking about some people's ability to mount a strong immune response to the vaccine. And there are clinical things that impact that. Age is one of them, but certainly other disease processes, other medications that you may be taking, like chemotherapy or other things, all can impact that as well. So, you know, that's again kind of the broader, bigger community picture that we're trying to put forth is, you know, that community immunity of, sorry.
That's okay. We'll move on to the next question. Dr. Gordon, you talked a lot about issues with COVID-19 and cancer patients. What is the most common issue that you're seeing?
The most common issue I see is trying to convince caregivers to get vaccinated. Now, that doesn't happen very often, but it does happen. And it's very frustrating because it's sort of like you don't understand the effect you may be having on your person. I think the other thing, you know, from a flow point of view, the advent of monoclonal antibodies created a great strain on our staff initially because we were the ones who had to do it all. Now it's gotten better. So I think it had a major effect early on in terms of monoclonal antibodies. And I think, yeah, it just changes the way we think about things. I mean, we have to be much more careful, and we just, the standard evaluation of a patient now has this extra thing. You have to go through the whole business about COVID-19.
Dr. Gordon, you mentioned that the COVID positive patients are following, you know, sort of a different flow through the cancer center, and you know, when they do have to receive other cancer services. Are you keeping track of and are you testing those patients regularly to make sure that someone who tested positive or negative in the past is not positive now as they're coming and going?
That's up to the individual provider to do that. And I think to some extent that's true. I can't say that it's always true. What I meant by that is if somebody's known to have COVID and they have cancer and they need to be treated, they have to come in a different way through a different door, and the people who are going to take care of them have on different PPEs. So they're dealt with differently. But I think the answer to your question is it is up to the provider. I think to some extent that's true. I'm not sure it's true all the time, to be honest.
Thanks, Dr. Gordon. Dr. Nefcy, are you seeing an increase in quote unquote incidental discoveries of COVID-19 among inpatients?
Yeah, you know, I would say we've just now really started tracking that more closely than we were because, you know, we've always had to, we screen everybody that's admitted to the hospital, and anybody that's in isolation gets reported up. But as we see increased numbers in the community, we are seeing a small increase in the number of those asymptomatic patients that are being admitted, but very few. And the reason that is, you know, many of those patients would be coming in for other things like surgeries or other procedures. And I think people are aware, as we have been in pandemic red, those procedures have been markedly reduced. So that we are really only doing those that are emergent. So we are seeing a handful of people that are being admitted with COVID rather than because of COVID, but very few.
Okay, thank you for that clarification. Dr. Nefcy, let's move on to the testing topic that you touched on briefly during your presentation. The question is, do false positive test results occur with antigen tests? And if so, how often?
They do, but I'd say rarely. And of course, I'm going off our testing that we do. And, you know, we've got a lab behind us that does a lot of quality control and those kinds of things. So yes, there is a small percentage all of those tests have a specificity and sensitivity, which is how often you would see a false positive or a false negative of, 93 to 95% or more. So there is always that possibility, but probably not as often as people think.
Great. Next question, Dr. Nefcy. With the vaccinated individuals that are becoming infected and hospitalized, are you seeing a trend in the brand of vaccination that those individuals received? For example, is one having a higher breakthrough rate than another?
Not that we have been able to discern, no.
Okay, so still as we mentioned earlier in the pandemic, any vaccination is better than no vaccination at this point, correct?
That is very clear, yes.
Okay,
And
great.
boosters
And
boosters are very important,
Yes.
whatever vaccine you got.
And Dr. Nefcy, can you speak to the CDC's new terminology around up-to-date versus boosted?
Yeah, that is sort of that difference between whether you have that third dose or a booster. And so it does, I think, create some confusion. For me, it's easier to say I've been boosted or I haven't been, and just so people are clear, when we're counting somebody as vaccinated, that means they've gotten either 2 doses of an mRNA vaccine and they're 2 weeks post that second dose, or they've had 1 of the J&J and are 2 weeks past that. That's how we're counting that. And so, the boosted thing is, I think, deserves some better clarity because, using boosted versus fully vaccinated versus up to date does cause some confusion. So just so people know how we're defining it on our graphic.
Well, and I think to Dr. Gordon's patient population, the ones who are immunocompromised were recommended to get that third dose as part of their regimen, not just
Correct.
not calling it a booster, right?
Correct. The immunocompromised members of our community, they're up to date or fully vaccinated would be those 3 doses. For everyone else, it would be 2. So
right. Somewhat confusing, but either way, talk to your healthcare provider and find out what's right for you. Dr. Nefcy, before we're almost out of time here, I just want to get to a couple more questions. Can you give us a status of pediatric patients within the Munson Healthcare system and across the state? Are we seeing an uptick? And specifically, the reporter is asking if we are seeing a lot more transfers of pediatric patients downstate from Munson Healthcare.
Yeah, we haven't seen a lot. We certainly, from the state data and absolutely from the national data, there's been a big increase in the number of pediatric hospitalizations. And again, when you look at a pure percentage, you are still at a low risk as a child. However, just by pure volume and just that denominator number, we are seeing with this many more cases, there's still a percentage of those new patients of kids that will be admitted. And when those kids come to the hospital, they are quite sick. So we are still seeing similar trends at the state level. Unfortunately, the state didn't update their data yesterday because of the holidays. So we have just the same information that we've had from as last week. So I can't really comment on where we are trending that way. And we continue to see a small number here in our Northern Michigan communities. Some of them get transferred and some of them are cared for here. But I do believe we've done a relatively good job in Northern Michigan when you look at our immunization rates compared to the rest of the state. And some of the work that we've done through our health departments and our schools, I think we've done a relatively good job of keeping our kids safe. There's still work to do and certainly still opportunity there. But yeah, we are still, last check, seeing an increase in the number of pediatric hospitalizations and admissions across the state.
Great, and thank you, Dr. Nefcy. And this final question, I'll ask Dr. Nefcy first, and Dr. Gordon, if you have any insight as well, you are welcome to comment about how many procedures have been delayed due to prioritizing COVID-19 patients. You mentioned, Dr. Nefcy, you mentioned that this has put an additional strain on the healthcare system.
Yeah, I could not tell you how many.
I don't think I have
It's a,
that number either.
yeah, it's a day-to-day thing, and to be clear, what's being prioritized are, those cases that really need to go, that can't wait, are being done. Those ones that we can delay safely are the ones that are being delayed. But I don't have a number.
Dr. Gordon, any other additional thoughts on that?
I'd like to make a comment because of this issue. We have not fortunately, very rarely, but we have had instances where people absolutely needed to be hospitalized, could not be in the short term because there were just no beds. And these are the one that comes to mind is a patient with acute leukemia. There's no way you can treat that patient as an outpatient. So I mean, we appreciate the fact that in this grand scheme, the Munson Healthcare has been very good to us because many of our patients, if you have malignancy, you need to deal with it now. You can't really wait. So we appreciate the fact that they have made adjustment for our patients, but it remains an issue.
Well, I want to just thank you both. I know how incredibly busy you are. Dr. Nefcy, it's always great to have you with the broader perspective. And Dr. Gordon, we really appreciate your insight today and everything you're doing to keep services open and to help those who are immunocompromised and those patients undergoing cancer treatment services at Munson Healthcare. Again, tremendous amount of work that you and your teams have done to adjust to the pandemic. So we really appreciate that and are so thankful and grateful to have those services in our community. So with that, I will again just thank our speakers today. And I just have a couple of final slides I want to get to as always. The one is just a summary of our community resources that are available. Great information is available at www.vaccines.gov. There's 211 Michigan, both a phone number and a website you can visit. There's the Area Agency on Aging of Northwest Michigan, as well as all of our local health department resources. And we are fortunate enough to have our health department partners join us again next week. So I invite you to tune in to that. And finally, just invite you to stay connected with Munson Healthcare through our biweekly e-newsletter, following us on social media, visiting munsonhealthcare.org. We have a great Q&A section of our website there, and it'll also help you understand any hours that may have been adjusted due to either staffing issues or other COVID-19 related issues. But you do check out our website first before you seek services. And then if you do have any questions, whether it be about COVID-19, the vaccine, or general health questions, you can call our Ask a Nurse line at 231-935-0951. So thank you so much for joining us today. I appreciate all of the reporters who took the time to log in and ask their questions today. And as always, if you've joined us on Facebook Live, we appreciate you tuning in and have a safe and healthy week, and we will see you next week.